Welcome back. We are now in the second part of the urinary system. We did finish um, well, the first function of the kidney, which is filtration, in the first set of slides. That's in part A. Now we're going to proceed into part B, and this will cover the second and the third function of the nephron, which is reabsorption and secretion. So let's start with tubular reabsorption. Tubular reabsorption quickly reclaims most of the contents, the contents that are actually the filtrate that gets into the tube, and then returns them into the blood. Remember that your filtrate really just filters the blood plasma without reference to anything that goes through. Anything that can actually be filtered will be filtered through the glomerulus. So we're losing a lot of water, we're losing a lot of ions, so we have to reclaim it back, and reclaiming it back, uh, it goes straight into the peritubular capillaries and back into the bloodstream. Um, there's actually selective it's actually a selective transepithelial process, the tubular reabsorption, and almost all organic nutrients are reabsorbed. Water and ion reabsorption is hormonally regulated and adjusted. It includes active and passive tubular reabsorption, and they follow two routes, the transcellular and the paracellular route. This is only like anatomy, very plain anatomy. Um, Water can actually go through or across the apical membrane and diffuse through the cytoplasm right here, and then can be transported right pretty much across into the interstitial fluid space, or it could actually be moving into the basolateral membrane. And this involves the lateral intercellular spaces because membrane transporters transport ions into these spaces. So the movement through the interstitial fluid follows and then into the capillary. Or the next one is a paracellular route. It doesn't go right through the cell, it goes in between two cells, and they move through the leaky tight junctions, particularly in the proximal convoluted tubules. There's many of these leaky junctions in the PCT, and movement through the interstitial fluid, then and back, then into the capillaries. So sodium transport across the basolateral membrane, and sodium ion is the most abundant of the cations in the filtrate, and it is transported across the basolateral membrane of the tubule via primary active transport. So it uses ATP. Okay, so we need ATPase that pumps sodium into the interstitial space. The sodium ion then is swept by bulk flow into the peritubular capillaries. So the sodium is also transported across the apical membrane, and with this one, it enters the tubule cell at the apical surface via secondary active transport or via facilitated diffusion through the channels. And active pumping of sodium at the basolateral membrane results in strong electrochemical gradient within the tubule cell. And these results in low intercellular sodium levels that facilitate pretty much sodium diffusion. And in the same token, uh, potassium leaks out of the cell into the interstitial fluid, leaving a net negative charge inside the cell, which also acts to pull the sodium inwards. So sodium reabsorption is also happening by primary active transport, and it provides energy and means of reabsorbing almost every other substance. Also, by it is also reabsorbed by way of secondary active transport, and pretty much here, the electrochemical gradient created by the pumps at the basolateral surface would give push, the needed push for transport of other solutes and organic nutrients pretty much would be co-transported, okay, with sodium, such as your glucose, amino acid, and some ions and some vitamins. So, is it also coming in reabsorbed um, passively? Well, there's passive tubular reabsorption of water, okay, and movement of sodium and other solids create an osmotic gradient for water. Remember what water does. Water follows salt. So whenever there's movement of sodium, water follows salt because sodium creates an osmotic gradient for water. Water is reabsorbed by osmosis and is aided by water-filled pores called aquaporins. So aquaporins are actually facilitators of the movement of water. In facilitated diffusion, this is not active transport. Facilitated diffusion is passive, okay, and aquaporin is the protein channel that does the job. And are in obligatory water reabsorption, the presence of aquaporin is making making the job or the movement of water an obligation. There's always aquaporins present in the proximal convoluted tubule, and therefore there's always reabsorption of water in the proximal convoluted tubule. Then you have facultative water reabsorption. This is only happening whenever aquaporins are actually inserted in the tubule. For water to be reabsorbed, aquaporins needs to be inserted in the tubule, and this happens in the collecting ducts. And the insertion of aquaporins is pretty much like um, uh, sensitized or done with the help of the antidiuretic hormone. So, in the passive tubular reabsorption of solutes, solute concentration in the filtrate increases as water is reabsorbed. This creates concentration gradients for solutes, which drives their entry into the tubule and the peritubular capillaries. Fat soluble substances, some ions, and urea will follow water into the peritubular capillaries down their concentration gradient. And for this reason, the lipid soluble drug and environmental pollutants are reabsorbed even though they are not desirable. So here is actually um, pretty much a bird's eye view of the tubular reabsorption of water and the nutrients. And in either way, they can use active transport or passive transport. Right here in the basolateral membrane, okay, the basolateral membrane, the sodium is pumped into the interstitial space right there. This is your interstitial space right here by the sodium potassium ATPase, and active sodium transport creates a concentration gradient that drives downhill, okay, sodium entry at the apical membrane, and it also drives the reabsorption of organic nutrients and certain ions by co-transport at the apical membrane. Okay, then it is also going to pretty much like result if you have aquaporins. This purple thing here is what appears to be the aquaporin. Water reabsorption increases. Increases the concentration of solids that are left behind. These solids can then be reabsorbed as they move down the concentration gradient. Then you have your lipid soluble substances, which diffuse by by the transcellular route and they go straight into the interstitial fluid and then into the capillaries. Then finally, there are ions such as chloride, calcium, potassium, and urea. They all diffuse by the paracellular route, and that's actually in between two cells. So, uh, what is TM? It's short for transport maximum. What is transport maximum? Well, in screenings, TM is actually uh, being watched out uh, because that's a way of measuring pretty much if we can still transport substances, or if substances cannot be transported, it actually stays in the urine. Now, uh, the transportation or the transcellular transport systems are very specific, and they're also very limited. They are uh, limited because they are um, pretty much like well, they are being served by carriers, and the carriers are not always there. I mean, they're there, but there's not really enough carriers really to do the job. So transport maximum exists for almost every substance that needs to be reabsorbed, and the substance needs to have carriers that would transfer them from one part of the cell into another. Okay, for instance, in the reabsorption process, okay, a number of carriers, there's actually a number of carriers in the renal tubules that is available to transport a certain substance. And so if the substance would be too much, too many, and there's only like an X amount of carriers, then the rest of the other substance will be left out and will not be transported. So when the carriers for solute gets to be saturated, the excess solute is actually left in the filtrate, and is obviously going to be excreted in the urine. This is the reason why people who have diabetes would have a lot of sugar in the blood, and the carriers for the blood in the reabsorption of sugar would only be an X amount. Then some of the sugar that has already been part of the filtrate cannot be reabsorbed back, and therefore um, there's there's now some sugar left in the urine, and that's going to be like excreted in the urine. Okay. So these are it's a good example for people who are hyperglycemic, and why uh, their urine is actually going to have a lot of glucose in it, because the glucose spills into the urine. So now let's take a look at the reabsorptive capabilities of the different renal tubules, from the proximal convoluted tubule to your let me see, let me just use my pointer. Okay, from the proximal convoluted tubule, okay, to your loop of Henle, okay, the descending loop, the ascending loop, the proximal convoluted tubule, and then the collecting ducts. Okay. So the proximal convoluted tubule is the site of most absorption, and all nutrients such as glucose and amino acids are absorbed here. 65% of pretty much sodium and water is actually absorbed, and um, many ions are also reabsorbed here, and almost all uric acid is actually reabsorbed here, and about half of the urea, which later is secreted back into the filtrate, is actually reabsorbed in the proximal convoluted tubule. Then you have the nephron loop, and the loop of Henle is here. This is the descending loop of Henle, and then the other side is the ascending, and this is the loop itself. So in the nephron loop, the descending limb is unique. The cells there allows water to leave. So the descending limb is actually permeable to water, but the solutes are not. So only water flows in the right here. You could see water moving out. So that's going to be very important in our formation of urine. We have to remember that. Then the ascending limb, on the other hand, is all of a sudden the cells here will not allow water to pass through it. So water here cannot live. But then the solutes are able to live here. So we're going to discuss the what do you call this, the importance of these properties in the countercurrent multiplier system of the kidney. Okay, so the thin segment, and you're looking at this here, it's actually wrapped around by simple squamous epithelium, is passive to sodium movement. The thick segment, though, this part here, has sodium, potassium, and chloride symporters and sodium ion antiporters that would transport sodium into the cell. And some sodium can pass into the cell by paracellular route in this area of the limb. Now, the distal convoluted tubule, there, that's the last one, and the collecting ducts themselves. Reabsorption here is hormonally regulated in these areas, and the hormone involved here is the antidiuretic hormone. It is released by your posterior pituitary gland. It causes the principal cells of the collecting ducts to insert aquaporins. Okay, so here you have facultative water movement, and by inserting aquaporins in the apical membranes, increasing water reabsorption. Now, an increase in antidiuretic hormone level would cause an increase also in water reabsorption here. Then you have also the hormone aldosterone. This aldosterone targets the collecting ducts or the principal cells of the collecting ducts, and that's actually right around this area here, and the distal convoluted tubule. So from this area right here, the distal end, all the way into the collecting ducts. Okay, it promotes the synthesis of apical sodium and potassium ion channels and the basolateral sodium potassium ATPases for sodium reabsorption. Okay, and remember that wherever sodium is, water will follow. Okay, as a result, sodium here will leave the body whenever you have what do you call this? Whenever you have aldosterone. Without aldosterone, daily loss of filtered sodium could be 2%, which is incompatible with life. Okay, so that's not really good. So aldosterone is needed in order to move water. So the function here is to increase blood pressure and decrease potassium level. Then you have your atrial, ANP, atrial natriuretic peptide. So your ADH, your aldosterone, they tend to increase blood pressure, but ANP is actually doing the reverse. It reduces blood sodium, resulting in decreased blood volume and blood pressure. It is released by the cardiac atrial cells if the blood volume or the pressure is actually elevated. And then you have the parathyroid hormone. It acts on the distal convoluted tubule to increase calcium reabsorption. And right here is again, as always, I am very fond of putting in certain tables that can help you study. So this is a sort of a summary of the reabsorption capabilities of the different segments of the renal tubules, from the proximal convoluted tubule all the way to the collecting ducts, and the mechanism by which they move water or they move substances. There you go. Now, the third function of the kidney is your tubular secretion. Tubular secretion is reabsorption in reverse. So whereas your reabsorption is where your filtrate now gets to be brought back into the blood because you pretty much have filtered too much. What if, there's actually a few things in the blood that needs to be moved back into and be secreted into the urine? That happens during the secretion process. And it occurs almost completely in the proximal convoluted tubule. And selected substances are moved from the peritubular capillaries through tubule cells or out into the filtrate. You have potassium, hydrogen, ammonia, creatinine, organic acids, and bases. And substances are synthesized in the tubule cells that are synthesized in the tubule cells are also secreted. Example of this would be your bicarbonates. So tubular secretion is very important because it disposes of substances such as drugs or metabolites that are bound to the plasma proteins. They eliminate undesirable substances that were passively reabsorbed. Example, urea and uric acid. It gets rid of um, excess potassium. This is actually what they call the aldosterone effect. And um, they control blood pH by altering the amount of hydrogen ion or bicarbonates in the urine. Okay, now let's take a look at certain phenomenon that will help us understand how sometimes we think that we are producing urine that is concentrated, and sometimes we produce urine that is not so concentrated. Let's take a look at and discuss the osmotic gradient in the renal, in the kidney itself. The renal medulla, and it's actually the middle of the kidney. Take note that right there right in the middle of the kidney itself, you have um, an osmolarity that is really high, 1,200 milliosmol. And then normally our urine is about 300 milliosmols only. So that's actually the isotonic. So 300 milliosmols normally. Then right there in the middle part of the medulla, the concentration is really big. Okay, so here's actually a picture of the nephron. Okay, and this is already this is actually enlarged. This is your nephron is really not visible like this, but it's just to show you the arrangement of the structures that pass through the osmotic gradient in the renal medulla. If you keep this anatomy in mind, it will help you understand the process of making very dilute or very concentrated urine. Take note that the osmolarity of the interstitial fluid in the renal cortex is isotonic at 300 milliosmol. Now, the isotonic increases, okay, the osmolality of the interstitial fluid would increase progressively from 300 all the way down to a max or to as high as 1,200 milliosmol at the medulla pelvic junction. Just imagine that. How that thing happens, we are going to discuss. So take note, guys, that it's also letting you know here that this has got something to do with the nature of the loop of Henle. Remember that in the previous slides I mentioned to you that the cells of the descending limb allows water to move. So this is actually um, um, permeable to water, but would not allow the salts to move in. So water moves out here, it keeps on moving out here. And so what's going on inside is that the um, filtrate now is getting to be very salty because it's losing a lot of water. So from 300, it loses water, and then right here at the loop area, it becomes 1,200 milliosmol. But then as it goes up again, the filtrate now goes up there. The sodium here now becomes very, the sodium now here becomes permeable, and therefore it leaves out. So pretty much this particular effect now is very prominent, most especially in the juxtamedullary nephron. If you have a very long hairpin loop, such as your juxtamedullary nephron, you could just imagine how much water we can lose and how much of the salt we can lose. We are actually producing very concentrated urine with our 15% of our nephrons being juxtamedullary nature. On the other hand, the vasa recta and the capillaries would preserve the gradient. It is actually the very long hairpin loop that pretty much would act as a countercurrent multiplier. They multiply the salinity of um, the filtrate. On the other hand, because whatever moves out, the water that moves out and the salt that moves out in the ascending limb is picked up by the vasa recta, then the capillaries are now acting as counter current exchangers. And then the collecting ducts and all the nephrons use this gradient to adjust the urine osmolarity. All right. So let's focus on how again this is happening. The countercurrent multiplier. Uh, let's take a look at the countercurrent multiplier. It depends on three properties of the nephron loop. First, the filtrate, the property that the descending limb is permeable only to the water. Okay, and then the ascending limb is permeable only to salt. So you know that in that regard, you know that the osmolarity of the filtrate, okay, in the descending limb is going to increase because as the filtrate goes down here, water leaves, and therefore everything here gets to be salty. And you could see it right here, okay, and the saltiness from 300 milliosmol goes all the way down and becomes very salty right here, okay. So as the filtrate now reaches its maximum concentration in the loop, it begins to go down because here this part of the loop of Henle now it would allow the pumping of sodium, okay, out of the filtrate, and pretty much that would now increase the interstitial fluid osmolarity. So sodium moves in here, so the osmolarity of the interstitial fluid now is increased here. Meanwhile, do not forget that while your loop of Henle is actually the one that would concentrate it, the one that would exchange it is actually the peritubular capillaries. Okay. So pretty much these are just the same things, and I must have moved it all. All right. So again, um, being that the tube is the one that multiplies the salinity, okay, of the filtrate, the vasa recta preserves the gradient. The vasa recta is highly permeable to water and solute, and therefore it is actually the one that counter current exchange the uh, the the osmolarity in each section of the vasa recta. The blood within the vasa recta remains nearly isosmotic to the surrounding fluid. The vasa recta are able to reabsorb water and solute into the general circulation without undoing the osmotic gradient by the countercurrent multiplier. So the exchanger itself, pretty much is highly permeable to water and solute. Okay, so a current countercurrent exchanger preserves medullary gradient by preventing rapid removal of water from the interstitial space, um, and pretty much removing also reabsorbed water. Water in the ascending. This is not the vasa recta. This is actually the vasa recta. Water in the ascending vasa recta comes from the descending vasa recta or is reabsorbed from the nephron loop and collecting duct. And then as a result, the volume of the blood at the end of the vasa recta is greater than at the beginning. So the established medullary osmotic gradient can now be used to form dilute or concentrated urine. without the gradient that was formed by the countercurrent exchange mechanism, pretty much we would not be able to raise urine concentration, okay, from to conserve water. Now, overhydration would produce large volumes of dilute urine, and here the antidiuretic hormone production decreases. Okay, pretty much urine osmolarity to about 100 milliosmol. If aldosterone is present, additional ions can be removed, causing the water to dilute to be even as low as 50 milliosmol. Dehydration produces small volume of concentrated urine. Maximal antidiuretic hormone is released, and here the urine pretty much osmolarity goes as high as 1,200 milliosmol. Now, in severe dehydration, 99% of the water is reabsorbed, and therefore there's going to be less quantity of urine, or maybe none at all, only 1%. So, urea helps form the medullary gradient. Urea enters the filtrate in the ascending thin limb of the nephron loop by facilitated diffusion, and the cortical collecting ducts, which is actually right by the cortex, reabsorbs water, leaving urea behind. Now, in the medullary region, very deep into the medullary region, now highly concentrated urea can leave the collecting duct and enters the interstitial fluid of the medulla. The urea then moves back into the ascending thin limb. Now, this contributes to the high osmolality in the medulla. Okay, so much with the movement of the filtrate. Let's now look at some drugs. Diuretics. These are chemicals that enhance or promote urinary output, and these are antidiuretic hormone inhibitors such as alcohol. Alcohol is a diuretic. Sodium reabsorb. This is actually where sodium reabsorption inhibitors. You have sodium absorption inhibitors such as caffeine or drugs or hypertension or edema pretty much will cause water reabsorption. Now, there are also loop diuretics that inhibit medullary gradient formation. And there's also the osmotic diuretics. These are substances that are not reabsorbed, so water remains in the urine. For example, in a diabetic patient, high glucose concentration pulls water from the body. So this one is already part of your lab, the clinical evaluation of the kidney. You've done urinalysis in the lab, so I'm not anymore going to discuss that, but this is going to be part of your exam. Okay, just to give you a little bit on it, but I'm going to give you most of it. Make sure you review again your urinalysis. I'm going to ask you questions on it in the lecture exam. So this is actually an examination of urine for signs of diseases. Can also be used for tests for illegal substances. And in assessing renal function, it requires both blood and urine example. And pretty much example, renal function can be assessed by measuring nitrogenous waste in the blood only. And these can also be used to determine renal clearance, where both blood and urine are required. So let's take a look at some chronic homeostatic imbalances. Chronic renal disease is defined as glomerular filtration rate that's lower than 60 ml per minute for 3 months. And this is where you are not really producing so much urine. Filtrate formation decreases, nitrogenous waste accumulates in the blood, the pH becomes acidic. They are seen in diabetes, mellitus, and hypertension. And is followed by renal failure. Okay, this is defined as glomerular filtration rate that is less than 15 mil per minute, and it causes uremia. These are ionic and hormonal imbalances, metabolic um, abnormalities, toxic molecular accumulation. So I remember one of my auntie died of uremia, of renal failure because of uremia. So symptoms of renal failure will be fatigue, anorexia, nausea, mental changes, cramps. And a treatment for this is hemodialysis or transplant. So let's take a look at, we're now winding now, let's take a look at urine, the waste liquid that we produce in our kidneys. It's 95% water, 5% solids, made up of nitrogenous waste such as urea from amino acid breakdown. This is so far the largest solid component. Uric acid from nucleic acid metabolism. Creatinine, which is a metabolite of creatine phosphate. Other normal solids found in the urine would be sodium, potassium, phosphate, sulfates, calcium, magnesium, and bicarbonates. Um, Abnormally high concentrations of any constituents or abnormal components, such as blood proteins, white blood cells, and bile pigments, may indicate pathology. So these are the abnormal urinary constituents and conditions that pretty much would, these are the conditions that would result because of the presence of these substances here, and why. So urine is all normally clear. If it's cloudy, it may indicate urinary tract infection. It's about pale to deep yellow. Uh, pretty much, this is a pigment from hemoglobin breakdown, and the yellow color deepens with increased concentration. There are some abnormal colors, pink, brown, smoky. This can be caused by certain food, bile pigments, blood, drugs. It is usually aromatic when fresh and develops a foul ammonia odor upon long standing, as bacteria would metabolize urea. Can be altered also. The smell can be altered by drugs or vegetables, as in when we are eating asparagus. Our urine smells bad. And also diseases can alter the smell. So patients with diabetes may have acetone smell to urine. And the pH of the urine is about roughly about 6. Okay, so it has a wide range depending on your diet from 4.5 to 8. So an acidic diet, like people who eat a lot of protein and whole wheat, can cause a drop in pH. And an alkaline diet for people who loves vegetable, okay, or when there's actually prolonged vomiting or UTI, it can cause an increase in pH. The specific gravity of urine pretty much is very close to water. Water has a specific gravity of 1. So it ranges from 1.01 to 1.035. Okay, because your urine, after all, it's not all water. It's made up of solutes in it too. So we're now going to go into a little bit of anatomy, which I know you have already taken in your lab. You have studied this in your lab. I want you to review this. This is still going to be part of your exam in the lecture. From the kidneys, urine now is going to be delivered into a pair of slender tubes. They convey urine from the kidneys to the bladder. You call them the ureters. Okay. These are retroperitoneal tubes. They enter the base of the bladder through the posterior wall. Okay, some homeostatic imbalance. Stones, kidney stones. These are stones pretty much that accumulate in the renal pelvis. They are crystallized calcium, magnesium, or uric acid salts. Large stones can block the ureter, obstructing urine flow. It can cause excruciating pain from flank to the abdomen. And there's a term for kidney stones, and that's nephrolithiasis. Urolithiasis will be the stones lodged in the ureters. Then you have the urinary bladder, which is a temporary storage for urine. It's a muscular sac. It's retroperitoneal. It lies on the pelvic floor posterior to the pubic symphysis. The males pretty much would have a prostate that's well, the males would have the urinary bladder like well, it is still on top of, I'm trying to imagine it's still on top of the prostate gland. Okay, but it is inferior to, the prostate is inferior to the bladder neck. So it is at the bottom of the urinary bladder, the prostate gland. In females, the bladder is actually anterior to the vagina and the uterus. And the urinary bladder has openings for the ureters, okay, and the urethra, and you call that the trigon. It's a smooth triangular area outlined by openings for ureters and urethra. Now, infections tend to persist in this region. The urethra, the final tube that drains the urinary bladder, is lined by pseudo-stratified columnar epithelium. Now, transitional epithelium, it is lined by transitional epithelium near the bladder and then stratified squamous epithelium near the external urethral orifice. So we have two types of sphincters that would help us control the flow of urine. The internal urethral sphincter has involuntary smooth muscles, okay, and at the bladder urethra junction, and it contracts to open involuntarily. The external urethral sphincter is voluntary. It has skeletal muscle. It surrounds the urethra as it passes through the pelvic floor. Now, the female urethra, which is about 3 to 4 centimeters, is tightly bound to the anterior vaginal wall. And the external urethral orifice, which is actually anterior to the vaginal opening and posterior to the clitoris. Micturition, the act of voiding or urination, pretty much is an event. These are actually 3 simultaneous events that occurs, well, first of all, by the contraction of the detrusor by the autonomic nervous system, opening of the urethral sphincter, again by the autonomic nervous system, and then opening of the external urethral sphincter by the somatic nervous system. So take note that number 1 and number 2 are both involuntary, and only number 3 is actually voluntary. So reflexive urination is the type of urination in infants, and happens only when the bladder gets to be distended and is activated by stretch receptors. It causes the excitation of the parasympathetic neurons in the reflex center, okay, and it leads to the contraction of the detrusor and opening of the internal sphincter. Now, inhibition of somatic pathways to external sphincter allows its relaxation and opening. Okay, now the pontine, as the child matures, the pontine control center would pretty much be the controlling center between age 2 and 3. Pontine storage center inhibits micturition. It inhibits the parasympathetic pathway, and it excites the sympathetic and somatic efferent pathways. Now, the pontine micturition center promotes micturition, and this is the one that excites the parasympathetic pathways and inhibits sympathetic and somatic efferent pathways. Now, urinary incontinence in adults usually is caused by weakened pelvic muscles. Stress incontinence is brought about by increased intra-abdominal pressure that forces urine through the external sphincter. So, such as whenever you're sneezing, coughing, or laughing, it can cause incontinence. Overflow, that's actually what you call stress incontinence. Overflow incontinence pretty much is when urine dribbles when the bladder overfills. This is when you know you really extremely need to go and you didn't go and the bladder overfills. So you tend to dribble. And pretty much that's the end of chapter 25, guys. We are now going to get into the endocrine system.